Hi everyone, welcome to Learner's Oasis. Today's topic is about ectopic pregnancy. Ectopic pregnancy is the pregnancy outside the normal uterine cavity. That is, the implantation takes place outside the normal uterine cavity, most often in fallopian tube. Ectopic pregnancy is a leading cause of maternal death in early pregnancy, with a mortality rate of 4% to 10% of all pregnancies or pregnancy related deaths in India. And 3.5 to 7.1% of maternal deaths in India is occurring due to ectopic pregnancy, according to NHP, the National Health Portal of India. So let us see in detail about ectopic pregnancy. An ectopic pregnancy. You can see a picture here. This picture shows there is a tubal pregnancy. The fertilized ovum is implanted in the tube. That is tubal pregnancy. It can implant anywhere. So an ectopic pregnancy is one in which the fertilized ovum is implanted and develops outside the normal uterine cavity. Normal uterine cavity से बाहर जाके implantation हो जाती है fertilized ovum का. ये जो है, this is normal uterine cavity. यहाँ ना होके कहीं भी जाके इम्प्लांट हो जाती है और वहाँ ग्रो करने लगता है, उसको कहते हैं एक्टोपिक प्रेगनेंसी. The incidence of ectopic pregnancy incidence has increased recently due to many causes. There, increased prevalence of the chronic pelvic inflammatory disease, tubal plastic operations, ovulation induction, and IUD, intrauterine device use. So ये cause है pelvic inflammatory diseases बहुत ज़्यादा होने की वजह से, ट्यूबल प्लास्टिक ऑपरेशंस की वजह से, ओवुलेशन इंडक्शन करने की वजह से और इंट्रायूटराइन डिवाइसेस के यूज़ की वजह से, ये सारे कॉजेस से जो है इंसिडेंस इसका बढ़ गया पहले से. Second cause is early diagnosis helps to detect some cases that in the past may have resolved spontaneously. पहले इतना टेक्नोलॉजी डेवलप नहीं हुआ है, तो आजकल इतना डेवलप्ड है मेडिकल साइंस, सो डायग्नोसिस अर्ली डायग्नोसिस करके इसको डिटेक्ट करने के चांसेस बढ़ गया. तो कुछ केसेस वजह से भी बढ़ गए. पहले जो केसेस, कई बार केसेस डायग्नोस नहीं होते थे, वो अपने आप रिसोल्व हो जाता था. Then early diagnosis and therapy have helped to reduce maternal deaths due to ectopic pregnancy. Ectopic pregnancy बढ़ गया तो भी इसका ट्रीटमेंट मेथड भी काफ़ी एडवांस्ड हो गया. सो इसी वजह से maternal deaths काफ़ी कम हो चुके हैं. reduced maternal death due to ectopic pregnancy because of the early diagnosis and therapy. Then the incidence varies from 1 in 300 to 1 in 150 deliveries. Here we will see the types of ectopic pregnancy according to the sites of implantation. Where it is implanted, accordingly it is classified. So it is mainly classified into extrauterine and intrauterine. Yeah, uterine ectopic pregnancies. Extrauterine is outside the uterus, and uterine means inside the uterus. So extrauterine includes tubal pregnancies. 97% ectopic pregnancies are tubal. Ovarian 0.5%, abdominal 1%, and this tubal pregnancy can be at different areas of fallopian tube, like ambula 55%, isthmus 25%, infundibulum of the tube 18%, and interstitial space 2%. Then abdominal pregnancy can be primary or secondary. Primary is very rare. Secondary can be intraperitoneal and or extraperitoneal, mainly broad ligament. Intraperitoneal is common. Now, uterine pregnancy includes cervical pregnancy less than 1%, angular region में है तो angular pregnancy कहते हैं, cornal region में हो सकता है pregnancy या cesarean scar area. The implantation can take place on a cesarean scar. It is less than 1%. So these are the sites of implantation. Accordingly, it is named, or these are the classification. So we have seen early in the last slide, we have seen the types of ectopic pregnancy. It is again listed here. Extrauterine, tubal, ampulla, isthmus, infundibulum, and interstitial. Then ovarian pregnancy, abdominal, can be primary or secondary, can be intraperitoneal or extraperitoneal. Uterine pregnancy, cervical, cornal, angular, and cesarean section, scar pregnancy. This is a picture of the sites of implantation. You can see the fallopian tube, infundibular region. It is implanted. Then ovarian pregnancy, then interstitial or cornal pregnancy, uterus. This is the normal uterine cavity. You can see here. This is the normal uterine cavity. No implantation takes place inside the normal uterine cavity, but it is outside. This is tubal isthmic region, then ambulary pregnancy, ovarian pregnancy, abdominal pregnancy, cesarean scar pregnancy, cervical pregnancy. All this time, these are the sites where it is implanting. Now we'll see the etiology of the ectopic pregnancy. Infections have a major role. Infections of the genital tract. Example, salpingitis and pelvic inflammatory diseases majorly cause the um, ectopic pregnancy. Then iatrogenic. Iatrogenic causes include one is contraception failure, intrauterine devices or sterilization operation failure. Then use of progestin only pill or post-coital estrogen preparations increase the chance of tubal pregnancy, probably by impaired tubal motility. So progestin pills use करने की वजह से post coital estrogen preparation से ही और इसकी वजह से भी ectopic pregnancy हो सकता है, tubal pregnancy हो सकता है, tubal reconstructive surgery to improve the fertility. It will increases the risk of tubal pregnancy significantly. So tubal pregnancy का एक major cause है reconstruct any surgery inside the tube. Intrapelvic adhesions following pelvic surgery. कोई adhesions हो रही है पहले से surgery करके, so उसकी वजह से भी implantation दूसरी जगह हो सकता है, ectopic pregnancy हो सकता है. ART, tubal pregnancy is increased following ovulation induction and IVF, ET and gift procedures. Ovulation induction procedures की वजह से tubal pregnancy हो सकता है. We will continue with the etiology. Previous ectopic pregnancy, that is 10 to 15% chances. Prior induced abortion significantly increases the risk. If the lady has undergone induced abortion, then developmental defects of the tube में कोई defect है, उसकी वजह से भी हो सकता है. Transperitoneal migration of the ovum का migration हो जाता है, transperitoneal migration इस वजह से हो सकता है. Contralateral presence of corpus luteum is noticed in tubal pregnancy in about 10% cases. Now we'll go to the signs and symptoms of ectopic pregnancy. Colicky cramping pain in lower abdomen on affected side. There will be colicky pain on the lower abdomen. Tubal rupture can cause sharp, steady pain before diffusing throughout the pelvic region. So अगर rupture हुआ तो बहुत ज़्यादा pain होगा, sharp pain, and it is very steady in nature. Then fetus expels into pelvic cavity. Tubal rupture हुआ तो fetus जो है pelvic cavity में चले जाते हैं. Heavy bleeding causes shoulder pain. Heavy bleeding होगा अगर rupture हुआ तो shoulder pain होगा. Then rectal pressure, vomiting, fainting attack. Syncopal attack 10% is due to reflex vasomotor disturbances. Then signs of shock, signs and symptoms of shock like rapid feeble pulse, cold and clammy extremities and skin, fainting, hypotension, etc. The clinical features include amenorrhea for a short period of 6 to 8 weeks. A history of vaginal spotting will be there. Abdominal pain is the most constant feature. Abdominal pain जो है सबसे कांस्टेंट फीचर है ये एगनाइजिंग और कोली की पेन हो सकता है या सिर्फ एक वेग सोरनेस होगा या पेन इज द पेन इज लोकेटेड एट लोअर एब्डोमेन में पेन होगा यूनिलैटरल पेन या बायलैटरल और जनरलाइज्ड लोअर एब्डोमेन पेन होगा पेशेंट को देन शोल्डर टिप पेन ये जो है रेफर्ड पेन होगा ड्यू टू hemoperitoneum. Hemoperitoneum will irritate the diaphragm, then that may cause referred pain to the shoulder tip. Then vaginal bleeding, slight and continuous vaginal bleeding होगी. Then expulsion of decidual cast. Decidual cast जो है 5% cases में decidual cast expulsion हो जाएगा होगा vagina से. We'll continue with the clinical features. General look of the patient is diagnostic features will be there like the patient lies quiet and conscious. Perspiration will be there. Patient has a blanched look. Patient is much worried and she pale. She looks blanched. This is diagnostic. Then pallor, severe and appropriate, proportionate to the amount of internal hemorrhage. जितने internal hemorrhage होगा उतना ज्यादा या severe pallor होगी patient को. Abdominal examination करने से पता चलेगा lower abdomen में tense, lower abdomen is tense, timid and tender. No mass is usually felt. Mass वगैरह feel नहीं होता. Shifting dullness present, एक shifting dullness feel होगा on abdominal examination. Bowel distension हो सकता है. Then pelvic examination, vaginal mucosa is blanched white. Uterus seems normal in size and slightly bulky. Extreme tenderness on the fornix. Then no mass is usually felt through the fornix. The uterus floats as if in water. एक floating nature होगा uterus का. Vaginal examination may precipitate more hemorrhage due to manipulation. So vaginal examination is not advisable because it may precipitate more hemorrhage. The changes in the fallopian tube in tubal pregnancy. The implantation of the tube occurs more commonly in intercolumnar fashion, that is in between the two mucosal folds. दो mucosal folds के बीच में implantation हो जाती है और distal change at the site of implantation is minimal. Distal changes ज़्यादा नहीं होगा implantation site में. Blood vessels engorged दिखेगा. Then the blastocysts burrow through the mucous membrane and lies between the lumen and the peritoneal covering, so called intramuscular implantation. So जो blastocyst है वो burrow होके नीचे चले जाते हैं और it is seen between the lumen and the peritoneal covering. Peritoneal covering and lumen के बीच में दिखता है वो, so इसको intramuscular implantation कहते हैं. A pseudocapsule is formed consisting of fibrin, lining epithelium and few muscle fibers. एक pseudo capsule form हो जाता है इसका implantation and the fertilized ovum के चारों ओर जिसमें fibrin और epithelial lining होगा और कुछ muscle fibers भी दिखते हैं pseudo capsule में. Blood vessels are eroded by the chorionic villi and blood accumulates in between the blastocyst and the serous cord. So blood vessel को कट करके कोरोनिक विले अंदर चले जाते हैं और ब्लड जो है पुलिंग हो जाता है एक्यूमुलेट हो जाते हैं ब्लास्टोसिस्ट और सीरस कोट के बीच में. We'll continue with the tubal changes. The tube site is distended and wall is thinned out. जो ट्यूब में जो जिस साइड में इम्प्लांटेशन हो वो जो है डिस्टेंड हो जाती है और thin हो जाता है उसका walls. The blood may spill from the fimbriated end and may cause hemoperitoneum. फिम्ब्रिया से ब्लड स्पिल आउट होके पेरिटोनियम में गिर जाता है तो वो हीमोपेरिटोनियम बन जाती है. Then the stretching of the peritoneum causes pain. पेरिटोनियम इतना ज्यादा स्ट्रेच हो जाती है इससे पेन होगा. ट्यूबल रप्चर हुआ तो मसल व्हेन मसल इस वजह से ट्यूबल रप्चर हो जाता है. मसल जो है सिरोस जो मैक्सिमम स्ट्रेच हो जाते हैं और नेक्रोस हो जाते हैं. इस वजह से ट्यूबल रप्चर हो जाते हैं. Then the trophoblast of ectopic pregnancy do not usually grow as that of normal pregnancy. Trophoblast का इतना growth नहीं होता जितने normal pregnancy में होती है. Then so the HCG production is inadequate compared to normal pregnancy. Normal pregnancy में जितने HCG produce होता है उतना नहीं होता इसमें tubal pregnancy में. Now we will see the changes in the uterus due to ectopic pregnancy. Under the influence of estrogen, progesterone, and from corpus luteum and chorionic gonadotrophin, there is varying amount of enlargement of the uterus with increased vascularity. Hormonal production तो होता ही है pregnancy की वजह से, so इस वजह से uterus enlarge हो जाती है. The decidua develops all the characteristics of intrauterine pregnancy except that it contains no evidence of chorionic villi. Decidua भी पूरा intrauterine pregnancy के जैसे develop हो जाती है लेकिन इसमें implantation नहीं होने की वजह से chorionic villi नहीं दिखेगा. When progesterone level falls due to fall in the level of HCG, endometrial growth is no longer maintained. Endometrium sloughs out, causing uterine bleeding. So progesterone level जैसे fall हो जाती है. HCG लेवल कम हो जाती है. सो एंडोमेट्रियल ग्रोथ इस वजह से मेंटेन नहीं कर पाता है हॉर्मोन्स का कमी की वजह से. सो एंडोमेट्रियम स्लफ आउट होके बाहर निकल जाती है जिस वजह से यूट्राइन ब्लीडिंग हो जाता है. इसको कहते हैं डेसिडुअल कास्टिंग. देन sometimes entire decidua is expelled out as a single piece through the cervix. This is known as decidual cast. That may be confused with a spontaneous abortion. So कई बार decidua जो है completely बाहर निकल जाता है जिसको कहते हैं decidual cast. वो spontaneous abortion जैसा दिख सकता है. Investigations: blood examination, hemoglobin, ABO and RH grouping, total white cell count and differential count, erythrocyte sedimentation rate, that is ESR, then chaldosynthesis through an 18-gauge lumbar puncture needle fitted with a syringe, a posterior fornix is punctured to gain access to the pouch of Douglas, aspiration of non-clotting blood with a hematocrit greater than 15% signifies ruptured ectopic pregnancy. Then estimation of beta HCG. The suspicious findings are lower concentration of HCG compared to normal intrauterine pregnancy. HCG level कम मिलेगा ectopic pregnancy में. Then sonography. The diagnostic features are absence of intrauterine pregnancy with a positive pregnancy test. Pregnancy test positive है लेकिन intrauterine pregnancy दिखेगा नहीं. Fluid, echogenic fluid in the pouch of Douglas is diagnostic. Then adnexal mass clearly separated from the ovary. Then rarely cardiac motion may be seen in unruptured tubal ectopic pregnancy. Cardiac motion भी दिख सकता है unruptured cases में. Management of ectopic pregnancy. Anti-shock treatment should be started immediately. Ringer lactate solution, that is crystalloid, is started. Arrangement is made for blood transfusion. Even if blood is not available, laparotomy is to be done desperately. Blood अगर arrange नहीं हो पाए तो भी laparotomy तो करना जरूरी है अगर patient को rupture हो रही है तो. When the blood is available, it is better to be transfused after the clamps are placed to occlude the bleeding vessels on laparotomy, as it is awfully hard to transfuse when the vessels are open. So blood जब मिलेगा ब्लड ट्रांसफ्यूशन देने के पहले जो ब्लड वेसल्स जो ब्लीडिंग ब्लड वेसल्स है उसको टाई करना या ओक्लूड करना जरूरी है लैप्रोटमी के टाइम में अदरवाइज जो भी ब्लड दे रहे हैं वो जो ओपन वेसल से बाहर निकल जाएगा After drawing the blood samples for grouping and cross matching, volume replacement with colloids is to be done. Colloidal solution. Then blood patient को volume replacement के लिए. Laparotomy has to be done in this case of ectopic pregnancy. Indications of laparotomy are patient hemodynamically unstable. Patient unstable है. Laparoscopy contraindicated and evidence of rupture is there. ये सारे cases में laparotomy जरूरी है. Salpingectomy is the definitive surgery. The excised tube should be sent for histological examination. Salpingectomy is the removal of the fallopian tube. Fallopian tube निकाल के उसका जो एक्साइज ट्यूब जो है वो हिस्टोलॉजिकल एग्जामिनेशन के लिए लैब में भेजना है. The ipsilateral ovary and its vascular supplies preserved. Oophorectomy is done only if the ovary is damaged beyond salvage or pathological. Ovary काफी damage हो चुका था oophorectomy करते. Oophorectomy is the removal of the ovary. So एक साइड का ovary निकाल दिया तो दूसरे साइड का ovary को जो है प्रिजर्व करके रखना है. Subtotal hysterectomy. The interstitial pregnancy. In interstitial pregnancy, the rupture rate is so big and the general condition is so low that most often acute subtotal hysterectomy is done. Hysterectomy अगर interstitial pregnancy है, even cervical pregnancy, corner pregnancy वगैरह में subtotal hysterectomy करना पड़ता है. इस salpingectomy का पिक्चर दिया हुआ है. This is salpingectomy is a surgical procedure for removal of one or both diseased fallopian tubes in the females. And oophorectomy is the surgical removal of the ovaries, both the ovaries or single ovary. So you can see here this is this fallopian tube is removed from at this level. It is completely removed. If it is oophorectomy, the ovaries removed like this. From this, it is cut off from the uterus. So this is salpingectomy and oophorectomy. The management of unruptured tubal pregnancy. Expectant management. There is the observation is done hoping of spontaneous resolution. Spontaneous resolution का expect करना, that is observation करते रहना होता है, इसको expectant management कहते हैं. Then medical management. Number of chemotherapeutic agents have been used, either systemic or direct local, under sonographic or laparoscopic guidance as medical management of ectopic pregnancy. Ectopic pregnancy का medical management के लिए कई तरह का chemotherapeutic agents use करते हैं. Systemic use here, local use कर सकते हैं, that is directly on the ectopic pregnancy under sonographic or laparoscopic guidance. उसमें से एक है salpingocentesis. Salpingocentesis is transvaginal passage of a needle with sonographic guidance into a tubal gestational sac with a live fetus is demonstrated, and the drugs are injected into the sac, terminating the ectopic pregnancy without सर्जिकल इंटरवेंशन. यहाँ पे ट्रांसवाजिनल नीडल पास करते हैं जेस्टेशनल सैक के अंदर ट्यूबल प्रेगनेंसी में, और फीटस अलाइव फीटस है ये डेमोन्स्ट्रेट हो जाते हैं. उसके बाद ये जो ड्रग्स यूज करते हैं जैसे पोटेशियम क्लोराइड या क्या कहते हैं मेथोट्रेक्सेट वगैरह, इसको इंजेक्ट करते हैं जेस्टेशनल सैक के अंदर कुछ फ्लूइड विथड्रॉ करके इंजेक्शन अंदर इंजेक्ट कर लेते हैं। जो ड्रग के इफेक्ट की वजह से फर्टिलाइज्ड ओवम का डेथ हो जाती है और बिना कोई सर्जिकल इंटरवेंशन के उसको रिसोल्व कर सकते हैं इसी तरह। So usually the drugs used for salpingocentesis are methotrexate, potassium chloride, prostaglandin, hyperosmolar glucose और actinomycin, ये सारे मेडिसिन यूज कर सकते हैं salpingocentesis के लिए। Then third method है for systemic therapy. Systemic therapy में a single dose of methotrexate 50 milligram per meter square is used. Given intramuscularly. Intramuscular injection देते हैं methotrexate का directly into the body and it will damage the fertilized ovum. So these are the medical methods of unruptured tubal pregnancy. Unruptured tubal pregnancy. The surgical management. We will see the surgical management. Conservative surgery. Conservative surgery is a surgery in which a part or a structure is retained as much as possible. The procedure can be done either laparoscopically or microsurgical laparotomy. Under this conservative surgery, first one is expressing out from distal tube. The fertilized ovum, which is near to the fimbrial end, it is expressed out from the distal tube, distal fallopian tube. That is one method. Second is salpingostomy. Longitudinal incision is made on the anti-mesenteric border directly over the site of ectopic pregnancy to remove the products. So the products are removed by putting a longitudinal incision directly on the site of ectopic pregnancy and it is removed. That is salpingostomy, and the opening is kept open. It is not sutured. So that is salpingostomy. Then salpingotomy. The same way like salpingostomy, the opening is made here the remove the products of conception, and here the difference is it is closed. The opening is closed by sutures. Then segmental resection. This is of choice in ischemic pregnancy. End-to-end anastomosis can be done immediately or at a later date after appropriate counseling of the patient. So the one segment is removed and the ends of the end of the fallopian tube is sutured together. The remaining ends. And there is segmental resection. One segment is removed here from the fallopian tube. It is done in ischemic pregnancy. Then expiratory, extirpative surgery. It involves the removal of diseased tissue or organ. The whole organ is removed. That is extirpative surgery. Salpingectomy is done in this under this procedure. It is done when the whole affected tube is damaged. If the tube is fallopian tube is completely damaged, salpingectomy has to be done. Then contralateral tube is normal. The other tube is normal, so one can be removed. Then future fertility is not desired. This couple does not want a future pregnancy, so it can be removed. So these are the conditions of extirpative surgery. So we have discussed about the tubal pregnancy. Now we will go to the abdominal pregnancy. So abdominal pregnancy, primary abdominal pregnancy, primary implantation of the fertilized ovum on the peritoneum. It is so rare. तो ये डायरेक्टली इम्प्लांट हो जाती है पेरिटोनियम में, ऐसे होता नहीं, बहुत ही रेयर है, लेकिन हो भी सकता है, देयर इज ए चांस. Secondary abdominal pregnancy. Secondary abdominal pregnancy is a condition where the embryo or fetus continues to grow in the abdominal cavity after its expulsion from the fallopian tube or the other seat of its primary development. So secondary abdominal pregnancy implantation ट्यूब में या ओवरी में कहीं हो जाती है उसके बाद वो जो है वहां से escape करके fallopian tube में से या ये जो है it is coming to the peritoneal cavity वहां पे abdominal cavity में आके वो grow करने लगता है that is secondary abdominal pregnancy. Abdominal pregnancy is almost always secondary, the primary site being tube, ovary, or even the uterus. The conceptus escapes out through the rent in the uterine scar. सो ये abdominal pregnancy हमेशा secondary ही होता है बहुत ही rarely primary हो सकता है ये कहीं से भी ट्यूब से या ओवरियन प्रेगनेंसी से या फिर यूट्रस से भी एस्केप करके एब्डोमिनल कैविटी में आ सकता है इवन थ्रू द scar of the cesarean section scar से भी वो बाहर आ सकता है so the incidence is about 1 in 3000 pregnancy with the use of ART the incidence is found rising आर्टिफिशियल रिप्रोडक्टिव टेक्निक की वजह से इसका इंसिडेंस ज्यादा हो रहे current incidence is 1 in 3000 pregnancies. Secondary abdominal pregnancy, the prerequisites for the continuation of fetal growth outside the tubes are perforation of the tube wall should be slow process, amnion must be intact, placental chorion should escape injury from the rupture, herniation of the amniotic sac with the living ovum, and the placenta should occur through the rent. Placenta gets attached to the neighboring structures and a new vascular connection should be re-established. Intestine, omentum and adjacent structures get adherent to the secondary sac. ये कुछ conditions है जो fetal growth outside the tube कैसे कब continue करने लगता है that is tube perforation of tubal wall is slow या amnion जो है break नहीं हुआ intact है chorion should escape injury from the rupture होने की वजह से ट्यूबल रप्चर या कोई प्रॉब्लम से उसको कोई इंजुरी नहीं हुआ कोरियन और amnion दोनों को herniation of the amniotic sac with the living ovum and the placenta should occur through the rent amniotic sac without any damage or injury वो herniate करके बाहर आना चाहिए placenta gets attached to the neighboring structures and new vascular connection should be re-established नया vascular connection re-establish करना है placenta को ताकि the fetus gets oxygen or intestine, omentum or adjacent structures get adherent to the secondary sac. Secondary sac के साथ कुछ organs जो है adhere हो गया तो ये सारे condition में fetal growth जो है continue करवाते हैं. Signs and symptoms. The history is suggestive of disturbed tubal pregnancy during early months. Pain lower abdomen and vaginal bleeding is often present. So पहले उसको ectopic pregnancy, tubal pregnancy हुआ है तो ऐसे history मिलेगा patient से या relative से. Minor ailments of normal uterine pregnancy are often exaggerated such as nausea, vomiting, constipation, pain abdomen and increased fetal movements. माइनर एलिमेंट्स जो है यूट्राइन जो प्रेगनेंसी का वो ज्यादा हो गया जैसे कि नोसिया वोमिटिंग कॉन्स्टिपेशन पेन एब्डोमेन fetal movement वगैरह exaggerate हो गया then signs in advanced pregnancy uterine contour is not well defined even by massaging the abdominal wall as the Braxton Hicks contraction is absent in abdominal प्रेगनेंसी एब्डोमिनल प्रेगनेंसी में जो कॉन्डोर्स जो है मिलेगा नहीं क्योंकि वो यूट्रस के अंदर नहीं है वो एब्डोमिनल कैविटी में है और ब्रैक्सन हिक्स कंट्रैक्शन भी एब्सेंट रहेगी एब्डोमिनल प्रेगनेंसी में Fetal parts are felt easily, and persistent abnormal attitude and position of the fetus on repeated examination is quite common. जो fetus है उसका parts बहुत आसानी से feel कर सकते हैं क्योंकि वो abdominal cavity में uterus में नहीं है, और fetus का position जो है हमेशा attitude position वगैरह बार बार change होते रहेंगे. ये सारे signs advanced pregnancy का signs है. Management: once the diagnosis is made, urgent laparotomy should be done irrespective of the period of gestation. So एक बार पता चल गया कि abdominal pregnancy है, तुरंत उसका डिसीजन लेना चाहिए कि laparotomy करके उसको end करने की pregnancy को. The continuation of risk of continuation of pregnancy, continue किया pregnancy continue किया तो क्या problem हो सकता है? Catastrophic hemorrhage, बहुत ही dangerous hemorrhage हो सकता है, heavy bleeding, then fetal death हो सकता है, increased fetal malformation, fetal malformation होने की chances बहुत ज़्यादा है, increased neonatal loss होने के 50% chances है. So these are the problems of continuing the abdominal pregnancy. Laparotomy. The ideal surgery is to remove the entire sac fetus and the placenta and membranes. So laparotomy करके ideally क्या करते हैं, entire जो fetus and उसका sac, placenta, membranes सब निकालना है. That is being done in laparotomy. This may be achieved if the placenta is attached to a removable organ like uterus or broad ligament. अगर ये इसका प्लासेंटा कोई यूट्रस में या ब्रॉड लिगामेंट वगैरह में अटैच्ड है तो आसानी से निकाल सकता है प्लासेंटा को. If the placenta is attached to vital organs, it is better to take out the fetus and leave behind the placenta and the sac after trying and cutting the cord flushed with its placental attachment. So अगर प्लासेंटा वाइटल ऑर्गन्स में अटैच्ड हो रखी है और उसको प्लासेंटा निकालने से ऑर्गन का डैमेज हो सकता है तो प्लासेंटा और साक जो है वही छोड़ देते हैं एब्डोमिनल कैविटी में, तो जो फीटस जो है उसको बाहर निकाल देते हैं और जो एंड है उसका कॉर्ड का, अम्बिलिकल कॉर्ड का एंड फ्लैश करके उसको कट करके वही छोड़ देते हैं, बिकॉज उसको निकालने से काफी डैमेज हो सकता है बाकी ऑर्गन्स को. Complications include secondary hemorrhage, intestinal obstruction and infection. इसका complication से secondary hemorrhage हो सकता है, intestinal obstruction हो सकता है, infections हो सकता है, ये सारे complications हैं. So we'll see what happens to the secondary abdominal pregnancy. इसका fate क्या है? Death of blastocyst. Blastocyst का death हो सकता है, उसका complete abortion कहते हैं. Massive intraperitoneal hemorrhage due to placental separation. Placenta separate होने की वजह से intraperitoneal hemorrhage हो सकता है. Infections हो सकता है, fistulous communication with the intestinal bladder, umbilicus वगैरह, umbilicus intestinal bladder वगैरह से fistula form हो सकता है infection के साथ साथ. Fetal death हो सकता है. Mummification, suppuration, adiposia formation, calcification, ये सारे fetal death होके ये सारे problems हो सकते हैं, मम्मीफाई होके अंदर रह जाए, सपुरेशन, पस फॉर्मेशन हो सकता है, एडिपोसिया फॉर्मेशन हो सकता है, कैल्सिफिकेशन हो सकता है, ये सारे fetal death के बाद जो डेड fetus के साथ हो सकता है. कंटिन्यू टू टर्म प्रेगनेंसी बहुत ही रेयर है, 1% चांस है पर टाइम तक वो ग्रो करने की. रिस्क ऑफ fetal malformation and deformation, अगर इवन इफ वो ग्रो करके मैच्योर या टाइम तक पहुंच जाए तो भी इसको fetal malformations हो सकता है, deformations हो सकता है. Next we will see the ovarian pregnancy. Here this is the ovarian pregnancy. You can see the pregnancy, the implantation is happening on the ovary, that is ovarian pregnancy. This is ovarian pregnancy here. Ovarian pregnancy, Spielberg's criteria in diagnosing ovarian pregnancy are tube on the affected side must be intact. Affected side में ट्यूब जो है इंटैक्ट है. The gestation sac must be in possession of the ovary. Gestation sac जो है ovary का पोजीशन में होना चाहिए. The gestation sac is connected to the uterus by the ovarian ligament. Gestation sac जो है uterus से connected है ovarian ligament से. Ovarian tissue must be found on its wall on histological examination. Histological examination में उसका ovarian tissue भी मिल जाना चाहिए इसका walls में. Then it is then only it is diagnosed as ovarian pregnancy. The embedding may occur intrafollicular or extrafollicular. Embedding जो है intrafollicular या extrafollicular हो सकता है. In either types, rupture is an inevitable phenomenon and salpingocentesis is the definite surgery. So कहीं भी किसी भी तरीके से इम्प्लांट हो उसमें रप्चर होना तो निश्चित है रप्चर हो जाएगी. तो इसमें साल्पिंगोफ्रेक्टमी करके उसको निकालना है जो टेस्ट होगा it has to be removed. That is the only treatment method. Ovarian resection could be done when the diagnosis is made early. Ovarian resection कर सकते हैं अगर early diagnosis हो गया तो ओफ्रेक्टमी की जगह. Next one is cervical pregnancy. Incidence it is very rare ectopic pregnancy. Incidence is 1 in 16,000 pregnancies. Definition: implantation occurs in the cervical canal at or below the internal os. Internal os में या उसके नीचे implantation होता है इसमें. Erosion of the walls by the trophoblast occur resulting in thinning and distension of the canal. Walls erode करते हैं trophoblast और इस वजह से there is thinning and distension of the cervical canal. In cervical pregnancy, the bleeding is painless and the uterine body lies above the distended cervix. So इसमें painless bleeding होती है और uterine body जो है cervix distended रहेगा उसके ऊपर uterine body दिखाई देता है इसमें. Then clinical features is का soft enlarged cervix equal to or larger than the fundus. Fundus से का size में या fundus से भी बड़ा cervix दिखेगा. Uterine bleeding following amenorrhea without cramping pain. Uterus से bleeding आएगा amenorrhea के बाद so cramping pain वगैरह नहीं होगा. Products of conception entirely confined within the firmly attached to within and firmly attached to endocervix. Endocervix में ही रहता है products of conception. A close internal cervical os and partially opened external os. Internal os close रहेगा और external os जो है partially open रहेगा. Diagnosis करने के लिए sonography करते हैं. Sonography reveals that pregnancy in the cervical canal and empty uterine cavity. Cervical canal में pregnancy detect करते हैं sonography से और uterine cavity empty मिलेगा. Treatment इसका hysterectomy. Hysterectomy is often required to stop bleeding. इसमें heavy bleeding हो सकता है thinning out of cervical canal की वजह से cervical cervix की वजह से. So bleeding stop करने के लिए hysterectomy करना पड़ता है. So we have discussed about the ectopic pregnancy, its different types and its management. I hope all of you understood the class. If you have any doubts, you can clarify it with me. Thank you so much for watching.